Alright guys, let's get busy talking about barbiturates. I like to think of barbiturates as the old-fashioned, the antiquated benzodiazepines that we never use anymore. We rarely use barbiturates in clinical practice. They have largely been replaced entirely by benzodiazepines. We will talk about the rare instances where barbiturates may be indicated, but I want to make sure you guys know that the reason why we don't use these anymore is because they have really nasty side effect profiles. They're actually really dangerous for patients, and the benzodiazepines have a much milder side effect profile, and that is why they've largely replaced the barbiturates. Now, these two drugs are incredibly similar, so let's talk about the mechanism of action because the test writers love to talk about the little discrepancies between these two categories of drug. So, in terms of mechanism of action, I'm using like this dark blue, dark purple color because it's very similar to the blue that we used in benzodiazepines, but still just a little bit different. So it's all about GABA A again. So remember, our theme was GABA A is agonized by alcohol, by benzodiazepines, and by barbiturates. And this is what makes all of these drugs really dangerous when it comes to withdrawal. I want you guys to remember that. Now, when it comes to how it facilitates its effects, it's going to have increased chloride channel opening duration. And now I bolded that word duration on purpose because it's so incredibly important here. So I'm going to like highlight it 5 times over because of how important it is for you guys to know this. So when it came to benzodiazepines, it was all about chloride opening frequency. So those chloride channels were opening more frequently. In barbiturates, that chloride channel is open for longer. So both are causing chloride ions to move through that channel at a greater degree, but the way they do that is slightly different. It's the difference between increased frequency and increased duration. And those are both super important to differentiate on test day. At the end of the chain, this leads to decreased neuronal firing, which leads to the clinical effects of barbiturates, which is going to be anxiolysis, a feeling of calm, muscle relaxation. This is all the positive things that we get from barbiturates. All right, let's talk a little bit about how barbiturates are going to affect metabolism. I think this is super cool. These barbiturates are cytochrome P450 inducers. And why is that important? What does that mean? Now, the cytochrome P450 complex, it metabolizes a lot of different drugs that we give patients. I'm going to paint a picture of a patient who's on warfarin who may have been given a course of barbiturates. So we know that these barbiturates increase the activity of CYP450. We know that CYP450 is responsible for the metabolism of warfarin. So if you gave a barbiturate to a patient, their CYP450 complex is going to be like, let's get busy, let's start metabolizing all the warfarin in the body. So all of a sudden, you have all the warfarin disappearing because CYP450 has been majorly induced by barbiturates. This patient's INR is going to go way down because they have no more warfarin in their body. So if they had a target INR of 2 to 3 because they were at clot risk, all of a sudden after this course of barbiturates, now they're really at risk of getting a clot. So it's important that you do a survey of all of the CYP450 involved drugs that you may be giving a patient barbiturates to. So I just want to highlight here to reinforce, we're going to decrease the concentration of any drug that is metabolized by CYP450 in a patient who is taking barbiturates. Additionally, we want to avoid this in patients with porphyria because we know that CYP450 is going to induce the pathway that leads to porphyrin production. So if we give a barbiturate to a patient with, let's say, acute intermittent porphyria, we may trigger an episode of acute intermittent porphyria in this patient because we are ramping up that porphyrin pathway via CYP450. And this patient is going to present with like abdominal pain and vomiting and a bunch of non-specific, really ugly symptoms, and it might all be because of the barbiturate. So it's important to take a med history and kind of connect all those clues on test day. In terms of the clinical uses of our barbiturates, usually these have pretty much all been replaced by benzodiazepines. However, I want to go over the names of some of the barbiturates so you can recognize them on test day. So we have phenobarbital, thiopental, pentobarbital, secobarbital, and the one that doesn't really sound like any of the others, but it's actually pretty important, is primidone. So let's talk about some of the clinical indications. We can use them for anxiolysis. I would much rather use a benzodiazepine because it has a safer side effect profile. We can also use them for induction of anesthesia aphasia, and this relates to their nasty side effect profile. They can induce somnolence and respiratory depression really quickly via that GABA A agonism, and this is really useful as an anesthetic agent where we have control over a patient's breathing and we're not necessarily worried about them being somnolent because we want them to go to sleep before surgery. We can also use the special barbiturate primidone for essential tremor. And this is going to be helpful in our patients who are suffering from essential tremor. These are usually elderly patients, but it will be really important to counsel these patients that they should not be drinking alcohol while also taking primidone. Let's talk a little bit more about complications here. So due to the GABA A agonism, which we know kind of causes this relaxation, depression effect, it's going to lead to dependence because a lot of people like that feeling. So we have to be aware of that. Like we talked about, it's all about GABA A here. So we're going to have synergy with alcohol and benzodiazepines like we talked about in our previous videos. So you never want to be taking any of these three agents in conjunction with each other because they're going to synergize that GABA A agonism. Remember, when it comes to GABA A agonism, we are worried about respiratory, cardiovascular depression, somnolence, and coma. That's what we're really worried about here. And the reason why benzodiazepines are preferred to barbiturates is because barbiturates have an incredibly narrow therapeutic index. And a narrow therapeutic index means that it only takes a little bit of drug for you to go from therapeutic and like, yay, we love these effects, to, oh my God, we took a little bit too much. Now we're in respiratory depression and going into a coma. So that's what it means to have a narrow therapeutic index. It's not a desirable thing. We like drugs with a wide therapeutic index because it gives us a lot of wiggle room. We don't have to worry about patients overdosing. In terms of antidote, there is no antidote like flumazenil for benzodiazepines. We literally just have to treat the overdose with respiratory support and blood pressure support in these patients with depressive overdrive. I just want to wrap up by saying that you can just lump barbiturates along with benzodiazepines for the most part in terms of a lot of their things. The one thing I really want you guys to focus on is the all about duration here. So the CL channel opening duration is the most high yield thing on this slide. Keep that straight and you should be good on test day.